Good afternoon, everyone. Thank you for joining us for our town hall caring for the caregiver here on Tuesday afternoon, as it is for me. It's morning for one of our guests, and we are very grateful to them for being with us very early in the day. Let me introduce our guests first. We have two of them. One is we're having some technical issues with the video, but we have a little bit of a workaround there. Let me introduce Liam Robbins first, who is the manager of CPE and an ACPE certified educator at Lankenau Medical Center in Wynwood, Pennsylvania. I think Wynwood is how it's pronounced. And then we're also joined by Claire Bohman, who is the executive director of Sojourn Spiritual Care at San Francisco General Hospital, the multifaith spiritual care department there. And Claire is also one of the lab's advisors, so we're very happy to have them as well. For those of you, excuse me, who have been on our town halls before, you know these are fairly informal affairs. We don't have a super laid out program. We're here to hear from you all and from our guest about what they're experiencing and just have a little bit more relaxed conversation about sort of the state of affairs where you are. So let me just sort of open up the conversation. I'm going to share my screen so you can see Claire in at least one format, even though we can't see them live on screen here. We'll have that, and then we can still see Liam at the same time as well. So for both of you, what are you seeing where you are? You're in two very different places, at least in terms of geography, and I'm guessing that in terms of the population being served and how the pandemic is being experienced there. What is it like for both of you? Let me maybe turn to Liam first while Claire is working on some tech stuff, but what are you seeing, Liam?
Well, so let me tell you a little bit about my hospital. We are part of Mainline Health System, which is 4 acute care hospitals, drug and alcohol rehab, and then a physical rehab. So we're a pretty big system. Lankenau is the biggest of the 4 acute hospitals. If we were to run at our capacity, I think we're about 375 for beds. So we're not a large system. But we are placed right on the line. Literally, City Line Avenue is outside the door of West Philadelphia and the suburbs of Philadelphia, Greater Philadelphia. So we really have a lot of health disparities happen in this area because on the other side of City Line Avenue, where it's West Philly, it is one of the most challenged neighborhood zip codes in all of Pennsylvania in terms of insurance and salary, socioeconomic status, education, health insurance, obviously, and good health care. And then on the other side, we have one of the richest zip codes in all of Pennsylvania. It's kind of a neat place to do chaplaincy and education because we have both of those coming together. So that also means we have a lot of different cultures, a lot of different faith groups are present here, and we have a large age range. So that gives us a lot of variety. All that to be said is we have a lot of folks who are at risk with COVID because they're either elderly or because they're coming from situations where they're living in close proximity to each other. They don't have good health care. They may not have the best nutrition. So they have a lot of other health issues, which makes them vulnerable.
You mentioned specifically, and this is something that I haven't thought about before, but the mental health and addiction services provided by your system. Mm-hmm. I can only imagine that has got to be a unique, what's the word I'm looking for here, encounter, I guess, with COVID. What are they seeing, and how are you supporting them from a spiritual care perspective?
That's a great question. Unfortunately, I don't have a lot of answers on that one because so one of my previous students actually got hired at that facility to sort of act as a chaplain and as a counselor. And so would be better able to answer that. I know that they're still seeing patients, they're taking precautions, but I don't know if they have any COVID patients there. I know about the numbers more for the other places in the system, including like the rehab. There's some patients there who have COVID. Lots of our patients who have recovered from COVID go to our own rehab to try to, again, regain their strength and things because they've been on a ventilator and bedbound for weeks. Excuse me. My hospital also has an ECMO machine, and so lots of patients get transferred here. So ECMO is the heart-lung machine that helps give the heart and the lungs a break. So it circulates the oxygenated blood to try to keep people alive and give those organs a chance to recover. That's been particularly important for COVID patients, and we've had some successes, which is is reassuring. We are at a place. I mean, there are other city hospitals, obviously in Philadelphia, that also have ECMO. My understanding from Pennsylvania's health organization is there's about 20 patients right now in ECMO in all of Pennsylvania, and I think there's about 3 that are here now. So we've been running about 3 or 4 with COVID who have done ECMO here and have done fairly well. So that's a pretty good percentage out of a whole state to be in my hospital.
Yeah.
Part of that is because we have such a good ECMO team. Our success rate for ECMO, generally speaking, runs a little higher than the national average.
Okay.
So that helps us be, it's an asset for us then.
And would you sort of rate, rate is a terrible term, but if you think about middle of nowhere in New York City, where does your health system kind of fall in terms of the impact and the intensity of what you're experiencing?
Right, that's a great question. We were preparing ourselves for a mini New York. Watching all of that break out, we thought, well, Philadelphia it feels like a small city, very similar, in some ways to New York, but not as large. And we're just outside of it. So we get a lot of that impact, especially with Hahnemann Hospital closing. So one of the major hospitals that folks who are under-resourced would go to kind of end up, some of them come here or they fill up the other hospitals. And so we get a lot of overflow. We are very thankful. I think our state has done a good job at flattening the curve. We never got to that stage. We had a lot of surge plans happening. I mean, we've seen a lot. We've had to go in diversion within our own system to kind of balance the high rate here. But we never got to the really intense places we were concerned about. And I'm really thankful about that. Hopefully it stays that way.
And I'm sure that we have some folks in the audience thinking, lucky you, because I know we have many colleagues who are experiencing or still way down in the trenches. Claire, let me turn to you. I know that in some sense, at least in this part of the country, we have this idea that California has been something of an outlier in terms of what was expected to be a really intense experience of COVID. What are you seeing in San Francisco general?
Can you hear me? Great. Okay.
Great.
Wonderful.
Great.
Just wanted to make sure because we've had some technical issues. Thanks. I think that I can resonate with a lot of what Liam's saying actually about, we were preparing for the worst and have been cautiously optimistic. I think kind of just holding that. The impact has been lower. I think we've done a good job of flattening the curve, so to speak, here in San Francisco. And in the Bay Area, the mayor in San Francisco declared a state of emergency before we even had any cases of COVID here in the city. And so we've had leadership that's been really proactive in the city. And so I think that's a big part of why we are where we are right now. And I want to just tip my hat off to our director of the Department of Public Health, Grant Colfax, who's lived through the AIDS epidemic. I think it's not a coincidence that we're a city that was so hard hit by the AIDS epidemic, and many of the folks who've been at the lead are people who've lived through that epidemic. And so I think that that's an important dimension to the way we've responded as a community here in San Francisco. The organization that I work for, Sojourn Chaplaincy, was founded during the AIDS epidemic. In the early 1980s, religious leaders were refusing to meet with people who were dying of AIDS because they were gay, primarily. And there was an Episcopal priest who said, this isn't right. And so she started organizing clergy to visit with people dying of what we now know as AIDS, and developed the country's first AIDS ministry training. And during that time, we trained hundreds, if not thousands, of clergy in how to provide non-judgmental, compassionate spiritual care for people who were dying of AIDS. And that program kind of morphed into as the epidemic shifted here in the United States, that program really morphed into a community-based chaplaincy training program. And so that program lives on today, and our our spiritual care department is really largely fueled by volunteers. And so I would say something that's been challenging for us as a spiritual care department is, as we went into shelter in place, like, many hospitals around the country, volunteers were not allowed to come on campus.
Right.
In large part because it's just really not safe.
Right.
So that's been something that we've had to adjust to. I think it's been hard for all of us as a community. We have a really sweet community of caring, I think, at Sojourn. And so it's been hard to have that separation and not be able to be connected with each other. We've been finding creative ways of for the volunteers to stay connected. So we've started a warm line, a spiritual care warm line, and right now that's just for staff, and it's staffed by a number of our more advanced volunteer chaplains who answer the phones. It's available in the mornings and in the evenings, kind of at the beginning of shifts and the end of shifts, whether it's the night or the day shift, because most folks at the hospital where I work work 12s, and so that's the number that staff can call to get support if they want a prayer or a blessing before their shift, or if they just want someone to kind of unload with, maybe before they go home. It's a big, I think it's always a bit of a transition for healthcare workers to go home. And I think this pandemic has made it kind of, it's even harder. It's even more jarring, that transition. So that's part of what the warm line has been for. And that's something that's kind of, we're just taking it day by day. It's, we got it up and running last month, and we're kind of just month by month figuring out what the sustainability of that looks like.
Yeah, and now that you have mentioned the implementation of this really great tool, which is, it's so old school in its structure,
Totally.
right? It's a phone
Yeah.
line,
Yeah.
but this is providing a service that is very desperately needed. For those in your hospital who are not volunteer chaplains, who are professionals, who are paid, what sort of adaptations have you all had to make to still carry out spiritual care?
Yeah, that's a great question. Well, we've been utilizing analog, I would say. So one of the things that we've started doing is we created a recentering line, and so basically all it is a voicemail that we update every day, and our chaplain Shelly Chesley is doing this every day, and it's just a minute and a half recentering kind of meditation message. And so staff can call that number and recenter during the day. And that's been super popular, and it's super analog. It's just a voicemail that we're just changing your voicemail every day, right? And then also Tele chaplaincy is something that we've been doing, calling into the rooms with patients. We're not currently going into any COVID rooms. So we're calling into rooms. We've also, the Borealis Foundation, last year, we were able to get a donation of some iPads, mostly to provide care. The intention was, and the way we were using it was around end of life, to have music and that kind of thing available for folks. But it's turned into this wonderful resource so that we could do video chat for patients at the hospital. And our care experience department has just gotten a donation of tablets from Google, and so we actually are now implementing tablets at the nurses' stations. And so the spiritual care department was kind of holding that piece, and the whole hospital is now holding setting up video chats for family members and patients. And I'll say, one of the things that I think has been really important that I just want to highlight in the video chats that I've set up is, when I'm doing video chats with family members, I like to start the video chat outside of the room and really kind of orient the family to the ICU or to the context that their loved one is in, because I think if we start the call just right there at the bedside and just on the patient's face, the family might lose a little bit of the context. And I think it's important for family members to understand the context that their loved ones are in right now. And so I just want to underline that piece, that I think, you know, it's important to make that heart connection and make the connection between the family and the patient. And it's also important, you know, to introduce the family to the nurse who's at the bedside and the healthcare providers, and kind of show them the machines that have the medicines, and that especially their patients, you know, if their loved one is unconscious. I think it's good to really orient the family to the context, because they would be getting all of that if they were visiting their loved one in person.
Yeah.
And so I think that's important to not lose track of.
You know, all of what you just described would happen automatically in an in-person visit. Now, they may not have a guided tour, but they're walking through these areas and they're going to see the nurse. The doctor is going to come in. You can ask, what is that doing? What is that doing? And I'm very glad that you brought this up, because at least in my mind, when I hear telechaplaincy, all I think about is the encounter with the patient and the chaplain, or the patient and their family at a distance. I don't think about all of this context that is wrapping all of this, that is sort of wrapped around all of this. And so I very much appreciate this idea of almost setting the stage for what a family is going to see. Because now that you mention it, you're absolutely right. If my phone rings and the first thing I see is a family member intubated and unconscious, I mean, that just sets a whole different tone from if you're able to begin that encounter in a little bit more gentle and just holistic way. So that's really, really interesting. Liam, what are you experiencing where you are? What's changed?
Well, I think a lot of the same things that Claire has talked about. We didn't do chaplaincy, telechaplaincy before. We didn't call. We would always visit patients. Those were our focus. Family would be our focus when we're here visiting. Obviously, staff care is always on our radar. We too lost some of our volunteers that we had, but surprisingly, the system allowed us to keep our CPE students. And so we had interns both at my hospital and at Paoli Hospital, which is a sister hospital. And we were able to keep them. We're able to continue with the summer if the students are willing to come, which is a big question mark. But the other folks who were volunteers, the other students, nursing students, were all sent away. So we consider ourselves really fortunate. The impact of that has been difficult, and please remind me to come back to that, because I'd like to talk about that, but I want to stick with what you're asking now. We didn't have those kind of electronics at the time, and the hospital didn't usually do video conversations with patients and families. You know, there's lots of legalities around that. So they did put a rush order on. I got some iPads, iPhones, so the floors all have them. The nurses are the ones who are doing a lot of that, because the folks who need it the most are the COVID patients, and most of my COVID patients are on ice. They're on a ventilator and they're sedated, they're not alert, they're not able to make those calls on their own. It's been very helpful for families who either are afraid or cannot come in at the end of life, because we do allow visitors, 3 at the max, to come in to someone who's emergently dying. So family is allowed to come even if they're COVID, but lots of families don't want to do that, or they're out of state. The nurse can often set up a phone conversation that set up that Zoom, so they can see their loved ones say their goodbyes before the patient is moved to extubation and eventually death. So that's been really helpful. I think what I like about what Claire is saying too is not just that the phone call, but setting it up that way helps it feel warmer. It also is reality. I had one of my students was calling a family member for someone, and the woman really wants to know when her dad's going to get shaved in the hospital. And while that is important, and that's such a dignity thing that we do for patients to help them feel clean and dignified, that's kind of at the bottom of what we need to be working on. And when people can see what it looks like when you look down my ICU and all the machines are in the hallway with these long tubes, you realize that, oh, there's something really different going on here. And to expect shaving, yeah, maybe not today. Okay. But have that assurance, but also have assurance that we're caring for her father, even if we're not able to shave him today. Trying to balance the reality of this. It kind of reminds me of why we want some families to see people when we're coding them and providing CPR, because yes, it can be helpful, but also is so damaging. I think that gentle reality check is helpful. So I appreciate that Claire can do that the way she's described.
Yeah, this is wonderful. We've talked about telechaplaincy on a number of occasions, and I use the phrase telechaplaincy to mean any sort of distance spiritual care, not just on the phone, but iPads, FaceTime, all that sort of thing. I think this is a really, really nice reminder, and maybe not a corrective, but it fleshes out this picture much more fully than we would think otherwise. I also hope that what is happening here and now can drive something of a conversation on, you mentioned the legalities. A lot of hospitals have either said absolutely no, we cannot do that. HIPAA doesn't allow us to do any of this kind of communication. Others have said, oh, of course it does. And some are in between, like, well, we don't really know, but let's honor the spirit of the law, if not the letter. I hope that we have a conversation about this afterwards, because this is not the last time that we're going to need to think about these questions. And there are plenty of other scenarios that we can imagine where it does make sense to think about providing spiritual care from a distance for a variety of reasons. So I think that one of the things that we should take away from this is what lessons can we learn even for you know, terrible pandemic situations in the future, but for other crises. You have both mentioned really great techniques and offerings for patients and for staff that you're both taking care of very well. But what are you doing to take care of yourselves and the other chaplains? This is a key question, and we talked about it a few weeks ago with frontline medical staff. For frontline spiritual care staff, what are you doing for yourselves, or what do you see your colleagues doing that's effective? Clara, I'll defer to you just since we were talking to Liam, but what's working for you?
Oh, it's a good question. I think early on in my CPE training, I went to a panel at CPMC out here at their CPE program, and there was one of the panelists who I can't remember who it is, so I'm sorry I can't quote them, but they said something that really stuck with me, which is self-care needs change over time. It's really important to remember that what you need to take care of yourself, what works one day isn't necessarily going to work the next day. And because it's not working doesn't mean there's something wrong. And I've been really thinking, I've been preaching that, I think, throughout the hospital with the healthcare workers. But I think this pandemic is really, I think many folks are having this experience of like what has worked in the past to take care of myself isn't working right now, and how do I need to change things up? And so I've been in the process around that as well. My home tradition is earth-based spirituality. I find a lot of connection with spirit through the earth, and so trying to spend time in my garden and with the plants has been an important part of self-care for me. I also have a practice that I call staring at the wall. So I come home at the end of the day and just try to, sometimes it's 5 minutes, sometimes it's 20, but of just staring at the wall and not having any stimulation. So no phones, no anything, just stare at the wall. And I don't know what it is about that, but there's been times in my life in terms of in my path as a chaplain where that's just been so critical. So those are some of the key things. I think also, my own spiritual practice also involves connection with the ancestors. The floor, my office is literally located 3 floors down from the AIDS ward from the 80s. And I really feel a strong spiritual connection with those ancestors. And so for me, a lot of my spiritual practice, I've really been feeling them so strongly in this pandemic. So looking towards the past and finding ways spiritually to connect with some of the strengths that got us through that pandemic and are getting us through that pandemic, because the AIDS is still killing people. The AIDS epidemic still continues. And also, one of my good friends who was a hospice nurse during the epidemic, Elaine McGree, is somebody who I've been talking with and, really, I think, receiving a lot of support from, just in hearing stories about how she got through that time. How did she care for folks? I think there's a lot of parallels, everything from, touch was such a big fight in the AIDS epidemic, to be able to touch patients. There was a lot of healthcare providers who said we don't want to touch anybody who has AIDS, and the nurses were, some of the nurses on the AIDS floor were very adamant that we need to be able to have physical contact, and it's clear that that's not how this disease is transmitted. And so that was a big part of the fight of that pandemic, was to be able to touch patients. And if you want, there's a documentary called 5B that's about the AIDS epidemic at the General, and you can check that out if you want to learn a little bit more. But I think it's interesting, and I've been reflecting a lot on how touch was such an important part of that fight, and how not being able to touch the patients that I'm connecting with and I'm serving is so difficult. I think the lack of physical connection and trying to socially distance while providing chaplaincy for somebody who's dying, their loved one is dying in the hospital, it's challenging. And so I've been in a reflective process of kind of the medicine of touch, which I think is such a powerful medicine that we offer as chaplains, and one that can be, if used when it's contraindicated, it can be really damaging, right? If it's used inappropriately, it's a powerful medicine, like all powerful medicines. And so I've just been reflecting a lot about that. And I don't know that I have a good answer or anything to offer there, but just want to share that that's been part of my reflective process.
I think when you mentioned trying to maintain this connection with people who have gone through something like this before, this is so interesting. And to take it in a little bit more academic route, I'm a historian by training, and one of the very first things that historians started saying when this broke out was start writing everything down. Your daily life, what's different, what has changed, what can't you do anymore, what do you miss? Write it all down, because someday, a century from now, someone's going to want to see that. And I think that's true from an academic perspective, but I also think it's true from a very human perspective. If we look back, the globe has been through pandemics before. This is
Yes.
not the first time. This one's different, of course, but this is not the first time. And to know that it happened in the past is not necessarily a comfort on its own. Great, they made it through it, but what if I don't? But I think that being able to connect with someone's experience, no matter what that experience is, but to just see someone else having gone through it is so important and so helpful to create a sense of community, especially in a time like now where what we define as community is so different, so radically different. When we can't,
Absolutely.
when
Well,
we
and I
can't.
just want to offer that, I completely agree with what you're saying, Michael. And, as a spiritual person, I think that community extends beyond the human world, and I think that, in my spiritual practice, it's, that part of that community is the ancestors who died in the pandemic. Part of that community are the bees who have been fighting die-off, right? In a process of, they've been struggling with a pandemic, and other animals and creatures. So I think that, we can look to the natural world and spiritual practices in that way of community. And that's my own personal spiritual perspective. And I know that's not everyone else's, but just offer that from my own.
Well, in terms of spirituality, there are as many spiritualities as there are people. And I think that hearing all of them is just so powerful. Liam, how about you?
So yeah, the self-care, I think what's interesting about it is that's something I always make my students, they're supposed to have choice about their goals, what are their learning goals when they come into the unit. But one thing I ask of each of them is you have to make a self-care goal. And students usually roll their eyes and think, I don't need to do that, or I can't do that. I'm going to school too, and I'm working and all that. And I said, I don't care, right? Because what works maybe in other times is not going to work now. Because when you're in the middle of CPE in a different context and you're seeing all these things, lots of different issues are going to come up. You're going to need to really focus on how to take care of yourself differently. And of course, this just like makes that explode. I think the hardest part for me is trying to balance that self-care, also trying to be a good colleague with the other chaplain in the department. There are only two of us at this hospital. And then trying to also care for my students, yet model self-care for them. And yet there's many days that I really was struggling. I'm an empathetic person, an empath. And so when I walk the halls, even though I'm not asking to take on all that energy, I am taking on a lot of that negative energy, that suffering. I personally believe in witnessing it. to be able to accurately pray about it in a very open interfaith sense, and then try to discharge it. But I found during this time, it's so much. It is not the usual amount to try and discharge when you go home. And, and I'm not making fun of Claire, but I kind of giggled when she mentioned staring at the wall. Sometimes I just find myself staring at the wall because I can't think. Not that I'm doing it purposely to relax, but that's a sign, right? So I need to do something different because I'm not functioning well enough. So I have worked really hard and making sure I'm not working a lot of overtime. My colleague and I split up the week and the days because of social distancing. So there's usually only one of us in the hospital at a time. A couple of my students are still here making rounds. Like Claire said, we're not visiting most patients. Anyone who's COVID, we're not seeing. Students, I've asked them to not really see patients unless they absolutely have to, and it's clear they're not COVID. Again, just trying to keep us healthy enough to be here and also to not carry something to another floor. But I think what's helped is it's finally getting warmer here in Pennsylvania. And so I could get outside. So I tore apart my shed in the backyard and built a new one and mowed the lawn this week. And so it's very much what Claire's saying, like it's getting back into nature and remembering the cycles of life, feeling good about my body, having a physical outlet for it makes a huge difference in how rested I feel coming back to work on Monday when it's my turn to come back in the hospital, And my education space is actually a house on the hospital grounds. And I haven't been there much because I've been in the hospital, and I was there last week. And it literally grounded me in a way that was just so powerful that I was like, oh, I need to remember to do this and come to this house and do some of my work from here. And there's a beautiful tree outside, and I go and I talk to the tree. And so I was just like so thankful that it's still there. Like
Right.
that ends up being my sort of touchstone.
Right.
In a very natural way.
There are so many things that I would love to talk about from this conversation. I could totally monopolize it from here on out, but I want to turn it over to the audience, the questions that people want to ask, and they range from the really nitty gritty to the more sort of broad. So what I'll do is, let me just say, for the sake of efficiency, Claire, if you could offer a response first, then we'll turn to Liam, and then I'll go back to a question just so we have a sort of an order of working here. This is a great question. How much have nursing staff taken up some of the strain for spiritual care for patients, especially if you can't go in? What are nursing staff doing?
I think it's an interesting time, and I think I'll just share I think there's a lot I could say about that, but I'll just share, because we can't enter the rooms right now, nursing staff have, particularly in the ICU, have done amazing work stepping into chaplaincy and stepping into spiritual care. And, I had a patient who really wanted to be, the family really wanted him to be anointed, and his, I'm in my own emotional process because I can't go into the room and offer that. But I met with his nurse and said, are you open to anointing this patient? And he said, well, I'm not religious at all, but I want to support my patient with whatever my patient needs. And so I gave him kind of a crash course in anointing. And we did it over video call, and I think it was a really profound experience for him, and a place of connection, and not a come to Jesus moment, or there's no conversion story or anything like that there. But I think that the real important part of that story is the way that he felt connected with the patient and the family by being able to provide spiritual care in a way that he never had before. I think it's important to remember that nurses and doctors, everybody in the hospital, can provide spiritual care for patients. It's not just chaplains who provide spiritual care. We're really the specialists, I believe, in spiritual care. And I think that this is a good time to help nurses and doctors and other folks in the hospital remember that.
I'm going to jump in and thank Claire for giving me a chance to plug the lab. We have 2 projects that involve spiritual generalist training specifically for nurses and doctors and other healthcare providers. If you go to the website and just search for spiritual generalist, we're very much aware of this, and how can chaplains help nurses and doctors provide kind of that frontline care, do maybe some sort of assessment, some sort of screening, where then a professional chaplain can come in and do the specialist work. So anyway, thank you. Let me get out of the way. Liam.
Yeah, and I'll just answer it briefly so we can get to some of the other questions because some of it is repetitive. I think our nursing staff has taken on a lot. And there are a team of people who have also taken on the responsibility of being there at patients' bedside as they're dying. So it's an end-of-life team. And a lot of them are nurses. There are some social workers on that team. So folks who know how to properly put on the protective gear appropriately to be able to safely go in and spend a little bit of time. So they're doing a lot of that. And so we do spend a lot of time trying to support them, the nurses, so they're not burning out from doing all that care.
Right.
We also have a spiritual care communion card, which patients can pray, or I've certainly, my colleague has prayed on behalf of the patient outside the room to say that they're willing to have taken, and they have the intention of being anointed. They have the intention of taking communion, and that is sufficient in this time. And that can be very reassuring to let the nurse know that, and they can explain it to the patient if they're alert, but also then to explain it to families when we're on the phone with them. And that's the other thing is by doing, while telechaplaincy is great, and I think it's going to be in the future, the drawback is it should never not also be on site. The best thing I can do is round the floors, come back and call family and say, I just peeked in and I saw your loved one and I prayed outside the room. I hope that's okay with you, and talk about that. And then they often want me to go back up and say a particular prayer,
Sure.
you know, so there's this, and then to be able to do that for them makes them feel connected that they're there and they have some control that they don't otherwise have. So I think it's really important to balance those together.
Yeah. Well, sorry, go ahead, Claire.
I just want to throw in here the papal indulgence that has been issued by the Pope.
Never a phrase that I would have expected to hear on a Chaplaincy Innovation Lab webinar, but you know what? It's a banner day.
It's really important for Catholic patients, I think, around the sacrament of anointing,
Yes.
that the Pope has issued an indulgence saying that anointing and confession is not necessary at end of life. And, you know, so one of the things that we're doing is bringing a copy of the indulgence to give to family members. And I think this is COVID and non-COVID patients who are in distress around this. So just offer that in case that's not on your radar for the folks who are on the webinar.
Well, and I think that this points to a broader issue of for patients who may be experiencing, you know, sort of a resurgence of some sort of historic religious feeling or trying to reconnect with a tradition. This is a great service of ministry to them of, you know, maybe they might have misconceptions of their own about their own tradition. And so being well versed in what is happening, and look here, if you are concerned about this, here is what your tradition says about X, Y, and Z, can be an enormous comfort. You know, and that what that looks like ranges so widely, but I think that being informed like that is a wonderful way of helping patients. This ties in a little bit with this great question, and I know that many people have been thinking about this, so I'm really grateful for this person to ask this. I am a hospice chaplain currently on week 8 of telechaplaincy. I am struggling with feeling that I am not doing enough since not seeing patients or colleagues has been isolating, and the idea of what work means is out on its head. I wonder how you navigate your own feeling of worth as chaplains in this very new context. That's a great question.
Liam, do you want to take that one?
Sure. I would say, I think that's, welcome to the club. I think even, you know, I mean, that's right. So that's part of the thing. So my wandering the halls, is it really doing anything? Well, I happen to think it does, because I believe in that energy and the power of that kind of intentional, open-eyed prayer and things like that. And presence means something, and witnessing people both getting better and struggling. I think a lot of what is helpful is families are telling us that on the phone, that they're thankful for those phone calls. And I try to remember, just like when we visit regular patients, most of them don't really thank us, right? Doesn't mean they're not thankful. So I just try to remember, like, the one person who does say thank you stands for 100. And I think The other thing that's helpful is doing things like this webinar where you get connected to your colleagues and you realize you're not the only one feeling that way. And the other thing is, it's, you know, I was telling my colleague in the office yesterday, the hospital, in a good way, is a black hole, right? There's so much need here for everybody during this because it's such a big crisis. Even though we're not hit as bad as New York, it's still a big, massive, you know, painful place. We can't fill it all, and we're not supposed to. You know, we can't take away our patients' pain ordinarily. So this is just another time, it's just bigger, of just recognizing, like, but it is worthwhile. That's why we're called to do this. Even, it's true, even if I don't feel it today, maybe tomorrow I'll feel it, you know. And for me, the students are helpful because I can see that what they're learning, and they're able to tell me how much they appreciate being able to still be in the hospital or to make the calls. So they're getting something out of it. So that helps me in those moments where I'm not feeling like I'm as productive as I'm used to being, or as I don't know, efficient or connected even, like she was, like your person was asking.
Sure. Claire?
I just want to echo what you said, Liam. I think that I don't know that I have a lot to add. I think that's yes, twinkles, as we would say.
Liam, you mentioned having an opportunity like this to be in touch with colleagues. It reminded me, I do want to let everyone know that if you're not a member of it already, and if you do belong to Facebook, if you find the lab on Facebook, just Chaplaincy Innovation Lab, we have a private group that is specifically just for chaplains. So if you join that, you have to answer a couple of questions, you know, where are you a chaplain, et cetera, because we don't want everyone coming in. But if you join that, it's a great place for conversation. I have seen really interesting discussions unfold that are ranging from super nitty gritty, I need something like a spiritual communion resource, can you send me something, to really big questions like, I don't feel like I'm doing anything. And it's fascinating to see that unfold. So I do invite you to join that and just have an opportunity to talk with your colleagues there. This is a really interesting one, moving from being on week 8 of telechaplaincy to trying to think about the future. What challenges do you anticipate when hospital settings begin to shift from telechaplaincy back to face-to-face, both for professional chaplains and for CPE students? Now, of course, we're speculating because we don't know when the end of this is going to be even in sight. But knowing what you know now, what's going to change?
Well, I don't know if you want to go first, Claire.
Go for it, Liam.
Okay, I can tell you that I just walked by the ambulatory testing, and they have already started putting signs on chairs so that people don't sit in this spot, so that they are social distanced in the waiting room while they're waiting for either the loved ones to come out of surgery, same-day surgeries, or they're coming out, you know, getting blood work for their tests. So we're at a place where if we manage to keep our numbers on the decline, that we will start re-engaging the outpatient services, because all of that stuff stopped. And we've really been hit hard where we just weren't doing a lot of that. And so we're trying to get back to that because people need that care that they've been going without for a couple months here. And so there's some of that happening very slowly, trying to figure out how to do that and change that. I think for us, as chaplains, I'm devising the summer unit to be some on site and a lot of telechaplaincy from the hospital grounds. And with the hopes that eventually certain units will have no COVID patients on it, and then they can start doing actual visitation there. But the problem is the tests aren't very accurate, and people who test negative one day, you know, we had a patient that was positive, went to rehab, tested negative, tested positive. So, and we don't know, does she have it again? Or is our test so flawed? And so we really want to protect the students, but at the same time, I want to protect the integrity of what I can teach them in chaplaincy, and some of that has got to be on site here and doing real stuff. And combining that with the phone. And so it's hard to balance that. I would say that a lot of us are really scared here. We're still on stay-at-home order here in this area of Pennsylvania until June 4th. And, you know, we're worried about, are we going to have a peak as people go out? Are we going to, what's going to happen even if we don't have a peak now, as the fall? Are we going to have another big spike? You know, the history buffs are telling us that the pandemic or the Spanish flu was much worse the second strike. So that's fearful for us, you know, and how do we do that and protect our students and still give good care and education?
Right.
Yeah, I just want to echo pretty much all of what you said, Liam. I think I'm in a very similar process. We're not a CPE program. Or sometimes jokingly, our training program is called CPE Light, because there's elements that are similar to CPE, but we're not CPE. It can be a good way for folks to kind of get a sense of if they want to pursue CPE. And so I'm in a really similar process of wanting to bring folks back, wanting to get, because our program basically just got pulled on hold, and trying to figure out how to bring folks back safely, how to maintain the integrity of the content of what we're teaching, because I agree with you, there's certain things
Right.
that you just can't teach unless you're in person.
Right.
And I've been in a process of, okay, well, maybe what we're doing is we're shifting gears and teaching what we can teach over the phone, because maybe that's the new normal for a period of time. Maybe our volunteers are on the phone for a longer time than maybe, I would want. I think what kind of the next steps look like, it's unclear. There's so much that's unknown in this time. So I think in terms of moving forward, how do we be with the unknown is some of what I'm thinking. So how do we plan for the future? How do I anticipate what is needed and plan, but also be present with what is right now, knowing that there's just so many moving pieces.
Staying flexible to it
Yes,
without driving ourselves crazy.
Yeah, I think
easier
that
said than done.
Yes.
simply
Sorry.
naming the uncertainty and finding a way to, if not be comfortable with it, then to at least tolerate it, is a really important goal to achieve, because there is almost nothing but uncertainty at
Yeah.
this stage of the game. And so to just acknowledge that I do not have control over a whole lot right now is a big milestone to get over. I want to ask a specific question, but also kind of blow it up a little bit. This person says, are you still being asked to officiate funerals of patients? And if so, how are you doing it differently? I think my broader question is, what about death has changed for both of you?
Mm. Well, I will say we actually haven't. I don't think we've been asked to do any, and there's a lot of regulations around what's happening for funerals here because there's still such a hot spot in that sense. I did love the Chaplaincy Innovation Lab on the end of life and funeral and how to do that, so we were prepared for that. But we haven't had a lot of requests for that. So we were kind of waiting for that, and we're trying to figure out how to do better bereavement calls and things like that. So we're actually going to bring back someone who's at one of our per diems and have them do some telechaplaincy with the bereavement. We're talking now as a system, as we start to again come up a little bit from it and have that tension broken. How are we going to do some memorial services? And are those going to be things just to honor those who've unfortunately died from this with staff? Are we going to open it up and do something on like GoTo for families to be able to sign in? So that's the next step we're starting to look at. We didn't really have the freedom to do that yet, if that makes sense.
Yeah.
Yeah, it's so interesting, Liam. You're all the way across the country, and I feel like we're just in really similar processes. It's very interesting. We haven't been asked to do that at the hospital yet. I think we're in a process of thinking about what does staff support look like in terms of grief support, and ritualizing the grieving process for staff, but also for family members. We have a Spanish grief group at Sojourn that we've had for a couple of years now. It's the only grief group in the city. We've shifted that to only grief group in the city in Spanish, pardon me. So we've shifted that to online. So we're kind of learning what does it look like to have a grief group online. And I think that's a really important need because over 80% of the hospitalizations for COVID in San Francisco are Latinx people. And it's, at the general, 30% of our patients are Latinx. And, over 80% of the hospitalizations that we've seen at the general are Latinx folks. And so I think, another important dimension of this pandemic that I think we haven't talked about yet, but that certainly we're seeing in San Francisco is, and throughout the country, are the racial disparities and the way that racism is playing out in this pandemic. I mean, I think I was just reading in the Times, you know, in New York, 1/3 of coronavirus deaths are African American folks. In San Francisco, African Americans are dying at 2 times the rate, or I'm sorry, in the Bay Area, African Americans are dying at 2 times the rate of everybody else with COVID. And, you know, I think this pandemic is revealing some already existing racial injustices in US society. And I think that, you know, how do we support grief and be present with the injustice that is happening with this pandemic. And you know, I think that as chaplains, you know, we have a moral obligation, and I think we have an important role in the face of the racism that's playing out in this pandemic. I think that chaplains, you know, we can name the racism as we see it. We can name the way these racial disparities are playing out. You know, within the healthcare system, with the administrations of our hospitals and ethics committees. We can also talk about it in congregations, in the media, on social media. I think it's really important for, you know, this is a bit of a controversial statement I'm about to make, but I really don't believe that chaplaincy is neutral. I don't think chaplaincy is neutral. And I think when we pretend that chaplaincy is neutral, we do a real disservice to the calling. And I think that chaplains have a really important role to play right now around the injustices and the disparities that are being revealed, because the cost of inaction is human life.
Right. Right.
And conversely, the cost of going out too soon for supposed economic reasons is also costly. And the folks who are usually going to be forced to go back to work are the folks who don't have a lot of protection, don't have, you know, who work blue collar jobs and things like that, or work in factories. And so that is the, you know, it's both, unfortunately.
Yeah. Yeah, I think, you know, who's working in the fields, who's making it possible for us to be safe at home, sheltering in place, who's delivering the packages. I think another dimension to the disparities here in the Bay Area is the housing crisis. It is so expensive to live here in the Bay Area. And, you know, many minimum wage workers and low wage workers live in very overcrowded situations where it's next to impossible to socially distance. And so I think that's part of why we're seeing those disparities. And I think it's really important for us to be talking about that, these disparities, especially as chaplains.
Well, I think that certainly, despite all of this being a massive tragedy on literally a global scale, it has given us an opportunity to say, look, this is a once in a generation sort of, it's going to reset the world in some ways. We think back to 9/11, changed everything. Wars in the past, they changed everything about society, and we have to rethink all of it. This is really throwing into stark relief things that we knew were here before, whether we wanted to acknowledge it or not, but now it's in our face, and or in your all's case, literally in your face every day. And so I hope that we can learn something from this. I just want to end here on a couple of more positive notes from the audience. Thank you all very much. This is a really nice idea. One person says, our palliative care teams have asked us to source twin knitted hearts. One of the hearts goes to the family and the other goes to the patient, and they can each physically hold on to it. That's a really, I mean, again, that is an old analog idea, but what a wonderful way to connect families and patients. Thank you. And there's another comment. It's wonderful to hear that CPE students were allowed to stay. Liam, this is for you. Whereas nursing and other students were not. This speaks to the honor and the integration of chaplaincy as part of the interdisciplinary team. Very true. And then finally, Kathleen Flynn, you're at almost all of our webinars, and thank you. You always ask these wonderful questions. Thank you for bringing up that chaplaincy is not neutral. If we are neutral in the face of oppression, we are complicit in it. So thank you. Thank you both for your time here. We're coming up on the top of the hour, and I know everyone has many things to do. For Claire, it's still the beginning of the day for you over on that side of the country, so we don't want to hold you up. Thank you both.
Well, what a lovely way to start the day. Thank you for this beginning. Thank you. Lovely.
And I want to remind anyone who happened to come in late, this is recorded, so no worries. You can see it later. This will be on the Chaplaincy Innovation Lab website in perpetuity. And you can find all of our webinars there on this and other topics. We have an entire page of coronavirus resources. I know many chaplains have said, there are so many resources, we don't even know where to start. And not just from us, but from all over the place. I can only apologize for trying to get as much out there as possible, but if you have, you know, some small moment of time in the day, please do check those out. There is a lot of stuff there. Thank you all very much. I look forward to staying in touch with both of you, and thank you for the work that you're doing. It's just remarkable.
Thank you, Michael.
Thank you all.
Thank you. To be a part of this.